Our last presentation, last but not least, is Kiefer Card. And Kiefer is a Master's of Science student under the supervision of Dr. Robert Hogg at Simon Fraser University. He works as a research assistant at the BC Centre for Excellence in HIV/AIDS in the Momentum Men's Health Study and is currently researching the role of the internet in the social and sexual lives of gay, bisexual, and other men who have sex with men, as well as other issues facing the changing landscape of gay men's health and the LGBT community. His other research interests include chronic health and the health impacts of climate change. The title of Kiefer's presentation is Sero-Adaptive Strategies of Gay and Bisexual Men with More Frequent Partner Change in the Momentum Health Study. Thank you, Kiefer. Let's get your slides up there.
Well, hello. The Danishes this morning didn't have enough beta blockers in them. I know because about halfway through hers, I start to get an eye twitch, which is my common, I'm really nervous and anxious trait. I'm thankful to be here with all of you who have put so much of your lives and energy into this research. I've only been researching HIV for about the past 6 months, and so I am sure by large I am the least of you. So I appreciate your guidance and what research you have done before now that has led to us to be able to research the topics that we're researching today. I ended up working on this particular project after I casually volunteered to assist in an email, and somehow I've ended up now here giving a presentation on the topic as one of the lead researchers on it. I recognize today that we're on the lands of the Coast Salish people, and give special tribute to them, that this is their unceded territory, but also recognize that they play an important role and that they are especially subject to the HIV epidemic in a way that maybe other populations aren't, and I recognize that today. And I'm very glad that Vancouver is so, as far as it is, helpful to those people. The background that we would like to cover is just a little bit above the HIV incidence. As you look on that, I just want to share my first time becoming aware of HIV stigma. And it was when I came, well, I don't know if it was my first time, but at least most salient. But I was coming out to my mother. She had come to visit me, and I was, I think, a sophomore or junior in college. And she, as mothers do, was harassing me about which one of my friends I was going to marry, and speaking of the girls. And so, of course, I did not have an interest in marrying any of them, but had not yet disclosed that to my mother. And so by the end of the day, I was so kind of like tired of it that after I left her, I emailed her, or I texted her, and I said, "Mom, I don't want to marry any of the girls," or something like that. And she said, "Oh, that's okay," and that's fine. And I'm like, "No, I don't think you understand. I'm gay." And she said, or I forget how she replied to the email, but quickly thereafter I went back to her hotel room where she was saying and kind of talked it with her. And the first thing she offered was to hire a prostitute to make sure. And that's very good of my mother, but I was not interested. And so the next concern she expressed after that was HIV. And it was, I think, for the first time that I ever thought about my sexuality in terms of HIV. I mean, I'm 26, for large part, I'm past the big epidemic, at least, coming from Utah and not being really aware of the issues that affect gay and bisexual men. And so I was not fully aware. But I think it opened my eyes to really understand that HIV remains an issue today. This is the prevalence in BC, or incidence in BC of new infections. As you can see, it's remained somewhat stable over time. And this is something that, second to maybe some of the stuff we heard about stigma today, just really makes me angry. And it really upsets me to think that we haven't yet solved this issue. And we haven't yet come to fully welcome people in and fully address the issues of stigma. And the fact of the matter is that in our community even, there are certain groups that face more stigma than any other groups. And some of those include these, what we like to call sexually active GBM. And they're prone to face all sorts of stigma, both from within and outside of the gay community. And another thing about these populations is that they're hard to sample. And sometimes it's the stigma that plays a role in them being hard to sample. Sometimes it's legal and structural ramifications that might happen, such as for an injection drug user, if they were to come forward. And all of these things kind of play to make research in this area difficult, and I think contribute to the lasting effects that we see today. And so our research aims to address this in two ways. One, we tried to take away some of the focus from being sexually active, and we use that term that you saw in the beginning, more frequent partner change. And so more frequent partner change was kind of emerged out of a discussion with our community partners, researchers on our team, and basically is what it is it's looking at an indicator that comes from the population itself. And so that's the thing with RDS sampling, which our study uses. It actually goes into a population and asks the people who are affected by the research to recruit. And so it kind of works as a snowball sample, and you're recruiting people. And I'll show you a figure on that in a moment. And then we let those people, and then we ask questions, and we look at the distribution, and then we use cut points to try to make decisions about it. And I'll show you more about that in the methods. And so that was our main objective, is try to understand what among those men, well, how are they remaining HIV negative? And what maybe resiliencies or what strategies do they use that best benefit them and that help them to remain free of all diseases and promote their sexual health. And so we included both HIV positive and HIV negative men in this, because health is not just about HIV. So I've divided the rest of the presentation up into a method section, a results and discussion section, and a conclusions. For those of you not familiar with the Momentum Health Study, it's a longitudinal cohort that began as a baseline cross-sectional study that looks at a variety of biobehavioral and social and medical factors to really kind of get a grasp on understanding the risk. Its main research objective is to really understand the effects of expanded heart access. However, many other important research questions can also be answered by the questionnaire. The eligibility criteria, and this is somewhat of an important thing to recognize, that our eligibility criteria is 16 and older. Of course, it's hard to really research younger populations than that. They're people who identify as male, regardless of necessarily what their birth gender was, and they're able to complete a computer-assisted interview in English. And so, right, that's limiting a lot of people out, potentially. And they have to live in the Metro Vancouver area. And so that's who they are. As to the Sero-Adaptive strategies that we looked at, one was to always use condoms. And so we just asked the question that you see there in quotes, always using condoms for anal sex. And that's the little logo from this ad I found that I thought was quite fantastic. It's still a blast, he says. And so, yeah, condom use is definitely one of the strategies, but men use lots of different strategies. And so we also asked about serosorting, which we defined as having anal sex without condoms, only with guys I know are the same HIV status. Dave and I serosort the way we know we're keeping the virus from harming others. Again, I don't know if it's a real ad or not, but it's Google image search. Here's another one. Anal sex avoidance, which some people are just avoid altogether. Having sex which doesn't include anal sex. Another one is the asking my sex partners about their HIV status before sex. And this is an important part of these prevention strategies that they use. And of course, without this one, other ones would probably not be very easy. And I tried to find a good ad for this to kind of show. And it was amazing how many of these partner disclosure ads that are even made by community organizations are stigmatizing. And so it's really interesting to see how stigma kind of even affects those of us who are trying to help prevent and end stigma. And then another Sero-Adaptive strategy was coming inside. We call this partner withdrawal for, I don't know, trying to sound academic, I think. And then our second to last is the strategic positioning, which for HIV positive men, they were being bottom, and HIV negative men, it was being top. And then our final one is the Sero-Adaptive strategy of viral load sorting, which is an emerging strategy and of particular interest as we understand that viral load is an important factor to consider in all of this. To really break down our variable by this more frequent partner change issue, we asked during the past 6 months, with how many males have you had anal sex with as top or bottom? We then broke that data up and identified about 75% of the data was below 7, and so, while 25% of the data was above 7. And as you can see, this strategy to kind of define more frequent partner change, it allowed us to take a somewhat less arbitrary cutoff when talking about this, right? Rather than saying this number means that you're highly sexually active and this one means that you're not. Using this strategy of more frequent partner change allows you to then look at the distribution of the data and say, well, these are the people who are having more partners and these are the people who have less. And that's just a matter of fact of the data, less so than drawing kind of an arbitrary line in the sand and saying, putting whatever our own judgments of that might be. And so it's a cleaner statistical approach than might just be us guessing where to draw that line. In our results, we had 719 participants recruited from 119 seeds. As you can see, these are the seed chains, and I think it's important that our research look like you and represent your social and networking patterns and my sexual and networking patterns and all of that. And so, as you can see, this comes with many seeds and chains, and people recruit from different areas, and then they try to recruit their friends, and those friends, of course, self-select into the study. But this is done to help create a more representative sample. In speaking to this, we look at our demographics, and then we adjust those things based on the homophily or the degree of sameness that the people have, and also the network size, so the size of these chains. And they use, which is beyond me, complex weightings that help adjust for it. And so you can see with regards to ethnicity, orientation, yeah, we oversampled on men who are gay, but the RDS weightings correct for that oversampling. And so again, this is aimed to make a more representative and more ethical approach to sampling. Again, you can see the results for residence and annual income. Annual income is interesting. We undersampled people who make less than 30K, so it increases that. And then this is for HIV status. Again, we slightly undersampled there, and so it increases the percent who are HIV negative. Getting into our results, we generally found that Sero-Adaptive behaviors were very prevalent among gay and bisexual men. And so this is really good news in a lot of ways. It means that men are taking the responsibility to make appropriate sexual decisions for themselves. They're not just sticking to one thing. They're evaluating what they can do best to prevent themselves from getting HIV. Of course, not all of these are necessarily proven by best evidence, but it nevertheless represents a desire for men that they're conscious and they're aware, and that sort of like stigma that we attach to, that was certainly attached to me, I think, by my mother, even if accidentally, was that we are aware. Like, we're very aware of what all of it means. And we definitely take important approaches. I mean, the 69% who use condoms, that's a very, I think, good number. Asking HIV status, so the disclosure is very high as well. And all of these things play an important role. And hopefully, as we find out which ones are more effective, we can better improve that. And so that's HIV negative men, and then HIV positive men. And the results are somewhat interesting if you look back and forth between the two, right? The HIV negative men seem to have a much different pattern of behaviors. And I think, to me, that speaks to the life-changing and world-changing experience that becoming HIV positive has. And it also speaks to the social and mental and emotional impacts that come into the decision-making between these two groups and impacts them. And then looking at specifically at whether or not these men who have more frequent partner change, the 7 or more partners, are at greater risk for certain things or greater prevalence is actually really interesting results as well. You can see from these plots here that men with more frequent partner change, or those with 7 or more partners, are more likely to ask HIV status, to viral load sort, and to top for anal sex among HIV-negative men, and less likely to completely abstain. And this shows that people who are engaging in more frequent partner change, they are actually helping, or they are actually maybe, in a way, taking on the next step of helping and promoting their own sexual health. So they are taking precautions. It's not just simply straightforward as I think a lot of neoliberal public health might make it out to be. And the same kind of results we see with HIV-positive men. They're almost 3 times as likely to practice seropositorting if they have 7 or more partners. I mean, that's quite important, knowing that that's an important way to reduce HIV transmission and seroconversion. They're also nearly 2 1/3 times more likely or at greater odds to ask HIV status, more likely to viral sort, and so on. And so these things, I think, speak really highly to the reality that men are doing things to help improve their health. In talking about our strengths and limitations, I think a big strength of our study is the RDS methodology. A couple weaknesses is, one, we ask, remember in our original question, we said over the past 6 months, have you done any of these things? Well, there is certain limitations to that, right? I could say that I've done that thing, but not necessarily done it within certain situations. And so one important way to alleviate that concern is to use event-level data, which actually looks at the individual sexual encounters, and you can look at the factors surrounding those sexual encounters. And I think that's an important, increasingly used approach to understand, though we did not use it in this evaluation. Because I think it's important when we're talking about stigma and when we're talking about sex and those sort of things, is to recognize that no single sexual encounter is just a pattern of behavior, right? It's a complex interaction between the person you're having sex with, a complex interaction with who you are, what your experiences have been, even what environment you're in. Are you in a hotel room? Are you in your home? Are you in a place where condoms are available or not? And so all of those things are important limitations that we don't fully capture in this study, and I would be remiss to not point that out. And then the other issue that we don't capture here is primary versus regular partner, right? That's an important part. People change their patterns of sexual behavior based on who they're having sex with. And they may not be taking all these unnecessary precautions if they just have the one partner. So future research areas, I think these are the important questions that I would like to see answered with regards to sero-adaptive strategies. While we have effectiveness in some of the strategies, I think it would be better to kind of understand them fully together. And then also, how do GBM assess the effectiveness of their strategies, right? That's another important part. It doesn't matter if science says it's effective or not. It understands what the people in our community think and how they make those decisions. And I think that's still today poorly understood. How might widespread uptake of these strategies affect condom use, which is the most effective HIV prevention strategy? And how might it affect HIV incidence? And that's an important part of the research. And all of that comes together to allow us to make recommendations and to promote these strategies so men have the evidence that they need and they have the capability to make the decisions that they want to make with fully informed decisions. And I think that's where research can play an important role, is allowing men and empowering men to make appropriate decisions about their sex lives. So just in conclusion, to summarize, the men with more frequent partner change, or those in the highest 25% of sexual partners, were more likely to employ a variety of sero-adaptive strategies to promote the sexual health of not only themselves, but of the partners that they love and of the communities which they are part. And that's, I think, really one of the most powerful parts about this, is that these men are real people. They're not just numbers. They're not just somebody who fits into a category or a box. And then also the research that's merited by this is further understanding what other ways we can promote and what most effective ways we can help these men to develop these understandings that we all need to make the appropriate decisions for our own lives. I'd like to thank all of our community partners, including him and Positive Living Society, the participants of the Momentum Health Study who come in every 6 months to complete a probably laborious questionnaire and take the time to do that to further the research that we do. And thank all of you for listening to me for 20 minutes.